Hi, so today's lecture is going to be about diaphragmatic hernias. And first, let's begin with congenital diaphragmatic hernia. I just need to say a line about these. Uh, I do not want to get into the detailing. I'll just talk about it in very brief. It is the hernia that's out here. Ideally, there is a complete diaphragm, correct? So in this there is a gap, there's a congenital gap that is present, and because of that the bowel herniates into the thorax. Okay, so there is a congenital defect of the pleuroperitoneal membrane. That's just an important point that I wanted to cover. A congenital defect of peritoneal membrane. Why pleuro? Because pleura is attached, so pleuroperitoneal membrane defect, and that is all I wanted to talk about when it came to congenital diaphragmatic hernia. Okay, right side, nothing much happens because the liver is present, so the liver won't allow even herniation even if there is a defect. So the right side is pretty much spared. Okay, so once we've spoken about that, okay, once I've spoken about that, I wanted to definitely talk about uh, the acquired or the adult uh, hernias. Okay, so let's speak about them too. Okay, so the adult or hiatal hernias, they are now, this is the most important topic that I wanted to stress upon, and this video will be short because they are just of two types. Actually, there are of three types as well. uh Type 1, type 2, type 3, and now there's a fourth type, which is paraesophageal. Before that, I want you to understand that the diaphragm has openings at T8, T10, and T12. Okay, so the openings at T8 is I so the mnemonic goes like I ate 10 eggs at 12. So I is inferior vena cava, 10 egg, so EGG, esophagus. uh at 12 is thoracic aorta and the thoracic duct. Okay, and so that this is the mnemonic that I like to remember. I ate 10 eggs at 12, and I find this mnemonic quite slick. Okay, so inferior vena cava is obviously I ate, uh, correct, and along with that there's also the phrenic nerve that's present, so you should keep that in mind. Then there's esophagus, and there's the vagus nerve at 10. Okay, just that E is helpful, otherwise it's not. Vagus nerve, and obviously the gastric artery, the left gastric artery. Okay, that's important, the G. Okay, so and at is aorta, the thoracic aorta, and then you obviously have the thoracic duct. Okay, so keep that in mind as well. So talking about them, once we've spoken about this important fact that I wanted to get across, let's directly jump into the hernias, right? Hiatal hernia. So first, type 1 is the simple one. It's is the more common one as well. It's called a sliding hernia. Okay, it's called a sliding hiatal hernia. Type 2 is the rolling. Okay, type 3 is the mixed one, and type 4 is the para esophagus. So let's talk about the type 1 sliding hernia. Let's go. So this is the stomach, this is the esophagus, this is the diaphragm, this is the right crust, this is the left crust. The right crust is going to compress it so that there is certain amount of tension out here. Okay, it is 3 to 5 centimeters. Intra-abdominal esophagus should be present. Okay, and then there is your very obvious stomach. What happens in a hiatal hernia or a sliding hiatal hernia is that the GE, gastroesophageal junction, that's present is actually displaced upwards. Alright, so the gastroesophageal junction is displaced upwards, and it goes from being in the abdomen. Okay, let me just mark it in green. This is the GE junction, this is the gastroesophageal. It's in the thorax, so now it lies in the thorax. Okay, so this is the most common, actually this is the most common diaphragmatic hernia as well. All right, so that's important. uh and the congenital hernia the most common congenital hernia is obviously, as I told you, the left posterolateral congenital hernia that we spoke about. Okay, so what is the complain, usually the patient is asymptomatic. He does not have a symptom. But if symptomatic, there is heartburn, or there is symptoms of gastroesophageal reflux disorder. That's about it. How do you want to do how do you want to investigate? You can investigate this by doing a CT with oral contrast, so that you can see the different you can see that there is certain amount of sliding up of the gastroesophageal junction. Or you could also do a barium meal. See, most of the conditions of the GIT can be diagnosed by a barium meal. Most of them, not all of them, obviously not of the rectum and the lower parts. Okay, so the symptomatic patients, if there is symptoms of the sliding type of hiatal hernia, the symptoms is going to be simple. You do a fundoplication. So what is fundoplication? Fundoplication is where you restore the length of the esophagus. Okay, uh, and you make sure that you get the G junction lower. So if this was the case, as we had shown, it's up, the G junction is up, right? So what you do is then you restore the G junction, and you bring it down into the abdomen. Okay, at minimum 3 centimeters. And also what you could do is that you could use the fundus. Okay, and fundoplication usually works that way, that you take the fundus and you roll it around. The G junction, so to make sure that the reflux does not occur, or the herniation does not occur. Then we have the rolling type, and this is the more rarer one, but more complicated and has more complications also. So what happens is that here is your stomach, and here is your diaphragm, and here is your GERD. There's no problem with the GERD, but what actually occurs is that there is a part of the part of the stomach that actually herniates out. So this is what is herniating out. Can undergo strangulation. Okay, volvulus, and then necrosis. So it's a life-threatening condition. Okay, and there can be longitudinal ulcer. Okay, it's if here there could be a lot of ulceration that could be seen. So because of the ulceration, it's called a Cameroon ulcer. Cameroon ulcer. And surgery, again, you'll have to reduce the hernia. Surgery, reduce the hernia. Repair the diaphragmatic defect. Repair diaphragmatic defect. That's very important, very important. And the crura, and tighten the crura. So there are three things that actually maintain the patency of the esophagus. First is obviously your crura. Second is the lower depth, or the intra-abdominal length of the esophagus. And obviously the intra-abdominal length has to be approximately 3 to 5 centimeters. That's very important. And a very important point is not that important, is something called as the angle of His. Okay, it's gastroesophageal angle. So basically this angle is called angle of this angle, which I am going to do in blue, is the angle of His. So there are three things that actually contribute to GERD, and these rolling hernias or sliding hernias are just different hernias that can actually lead to GERD or can worsen. Actually, sliding definitely can lead to GERD, but not the rolling type. And fundoplication is a surgery that we will also see in GERD. We will definitely see that in GERD, because fundoplication is very commonly carried out. Laparoscopic fundoplication, a Nissen's, a Door, one of them, where you have to actually take the fundus and you have to maneuver it around the esophagus to make sure that the sliding does not occur. So this is actually the fundoplication that we can look at. Okay, so fundoplication, something like that. Nevertheless, this is what I wanted to speak about when I went into the congenital and the acquired diaphragmatic hernias. Thank you very much.